Somehow we got it to work. It just worked. What did you do? I'm curious. It's working. Thank you.
I don't think you have the correct Windows.
What did you do? Because I want to know.
Yeah.
I don't want to like go back and like disconnect it.
I just want to see the video.
So we went to
You went to call,
yeah.
and I think you maybe just didn't select the correct.
Which one did you select? It's okay. You can go back in and just look. We can look at it.
I think you went for KPAT Teams.
And
Not
it
sure.
should be KPAD Zoom.
Yes.
That's what I did. Thank you for letting me. Yeah, perfect. And then I can share screen. I know how to do that. There we go. Thank you. Yay. All right. Yeah, I'm old and I struggle with technology, but don't judge. All right. So we're gonna, my plan is to be done by 12:30 with both lectures. That sound like a plan for you? So if you want to eat snacks, do whatever. We're just gonna go, we'll take a break. We'll just bomb and go down by 12:30 and people can get on the road, including me. All right. Yeah, including me. I live really far, so getting on the road is important, but we'll get the, most importantly, we'll get the information presented to you so you can understand. Have you had any information on malignant hyperthermia yet? I'm seeing yes. Can you tell me what you've had? What information had you had about it?
No information.
But it's a
Genetic disorder.
genetic disorder. Indeed it is. What else?
No inhalation, yes.
No inhalation agents, and then no also. So you guys got that. Excellent. What else about it? Can it cause the death of a patient without being rapidly identified and treated?
Yes.
Would you know how to identify it? You're not going to be actually doing that, but you're going to be helping in the resuscitation. Yes, sir.
Raising temperature and high end-tidal CO2.
End-tidal CO2, excellent. End-tidal CO2, most reliable sign. This is going to be easy. This is going to be review for you. I'm also going to want you to understand the pathology. You don't have to say it on a test. It's not going to be on your boards. But remember, my focus is always, if you don't understand it, understand what this is, basically you've memorized a whole bunch of different facts. And in the future, when you graduate, you'll forget everything. So I want you to understand what this is, why it occurs. Why can't you give sucks? Why can't you give an inhalation agent? How does dantrolene work? All of those are part of remembering this whole process. Like I said, the good thing is it doesn't happen often, but when it does, it is a true emergency. And when it is a true emergency like this, who manages it? Anesthesia, and that includes you. You are part of anesthesia. We will be depending on you, okay? Tony and Sarah in the future are going to be going over everything you need to do in greater detail that I know with the anesthesia machine. Because she said you can't give inhalation agent. How does MH become triggered? By giving either succinylcholine and inhalation agent. So once I've been giving the agent, it's in the machine. The molecules of the agent are in the machine. Once I determine someone has MH, I don't want them to get any more of that chemical. How do I make it stop? We'll talk about it. I'll show you what we can do, but who knows the machine better than anybody else? You, better than anybody else, okay? All right, so let's start. Malignant hyperthermia. Malignant is a bad word, right? That is associated with suffering, death, all of it. Hyperthermia. What does hyperthermia mean?
High body temperature.
High body temperature. Good. These are objectives. Yeah, I don't like objectives. All right. So what is a hypermetabolic state? Question, and this is one of the best ways that I've ever come up with to explain this. You guys exercise, right? You know why? Because you're part of Kaiser and you need to thrive. So you exercise. When you exercise, what happens to you? What happens to your body? Do you breathe faster? Do you get warm? Do you get hot? Like if you exercise a lot? Okay. What about your heart rate? Does your heart rate go up? Yeah. Okay, good. As you're working your big muscles, right? Has anyone exercised to the extremes, like doing sprints and stuff like that? In any human being, you can exercise, but even in the most trained human, there is a point to where exercise is so extreme, everybody will stop because it simply hurts too much, or your body cannot keep up with the metabolic demands and you will lose consciousness, right? What do you've heard of people running in races or pushing themselves to the extreme? What happens? They get dizzy, they lose consciousness, they puke. That's the body's way to say, stop, no more. And as you stop, the amount of oxygen the body needs is less. Heart rate starts to fall, breathing starts to fall. It starts to reverse itself. Ready? MH is the most extreme exercise you could ever do. But you can't stop because the muscle tension and contraction, which is the disease state, is not controlled by your brain. When you exercise, you can stop at any time. The brain will tell you, I've had enough, stop. But in MH, the muscle contraction is not controlled by your brain. It's controlled by the muscle pathology associated with the agents, which we're going to talk about. So do you understand that? Hypermetabolism. When you exercise, you're hypermetabolic. If you have MH, you're hypermetabolic. Last thing, what is your body screaming for if you're hypermetabolic? In a hypermetabolic state, what does your body need?
Oxygen.
Oxygen, and what'd you say? And energy, that's right. So you need oxygen to be efficient at creating energy. In this case, ATP, right? You guys know that. Are we good so far? In humans, MH is most likely triggered by our anesthetic agents, period, end of story. And it's those two. So can we give narcotics? Yes. Can we give dexmedetomidine? Can we give vasopressors? Everything is fine. With the exception of, let's review, inhalation agents, right? So can I give SIVO? Okay, but how about if I don't give SIVO, can I give ISO? Can I give DES? No, it's all three of them. We cannot give any of them. And succinylcholine. How about rocuronium? Can I give rocuronium? Yeah, it's a paralytic, but it works in a different way. All right. We're going to talk about what ryanodine receptor dysfunction is because that's the key. That's what starts this disease process. It's what causes the muscles to contract and not stop. Your brain is not under control of this ryanodine receptor stimulation. And as you guys said, why is there receptor dysfunction? Because it's an inherited genetic disorder and can result in death if it's not treated quickly. So think about yourself, think about your body. You guys are healthy young people. Think about most extreme exercise you can do. What is your heart rate? You're running, you're sprinting. What's your heart rate?
140 over.
140, 150, 160. For you guys, that's perfectly fine. Now, at some point, you're going to stop. How long can you sustain a heart rate of 160? You healthy people. Long periods of time, but not forever. Now, take our general surgical population. Are they all healthy young people? No. So therefore, the longer this goes on in terms of not treating this disease, especially if someone has other pathology, they're going to do really poorly really quickly. So let's talk about, I told you this is not on your test, but I wanted, and you guys already seem to know the pathology and why this occurs, pieces of it, but let's talk about it. So someone already said, patients become hypercarbonic. You already said we need cellular energy, ATP. You already said we need oxygen. It's all there. All right, so let's start at the very beginning. I'm gonna narrate. Can you see the cursor? Where's the cursor? Oh, there it is. There we go. Okay. No MH. This is just normal physiology. I want to move my arm. My brain says, move my arm. So a signal gets sent down my brain, right, from my brain, down my spinal column, out to nerves, to this nerve. This happens to be a muscle cell, one cell that makes up muscle. There are millions and millions of these, this is just one. So here we are, and I have an action potential. I want to move my arm. The action potential comes down here to this particular receptor. And you'll notice this receptor here is called RY ryanodine. So remember on the first page, it says that MH is caused by ryanodine receptor dysfunction. That is a ryanodine receptor. Okay. Under normal conditions, normally, when I want to move my arm, what needs to happen is, in order for muscle contraction to happen, calcium needs to interact with muscle. Without calcium, muscles do not contract and relax. So I want to move my arm. Calcium comes out of this organelle, SR. You can memorize it or not, I don't care. You've heard it, sarcoplasmic reticulum. Inside the cell, it is a reservoir for calcium. I want to move, stimulation, calcium release, interaction with muscle, muscle contraction. I want to stop moving my arm. I'm done. What happens is this action potential stops. Calcium then moves from the muscle back into the sarcoplasmic reticulum. And the calcium is in here, it cannot interact with muscle. And therefore you don't have muscle contraction. You understand that normal physiologic process? Good, okay. So let's throw so what is MH? How does it work? Ryanodine receptor dysfunction. So what happens is you give sucks or you give inhalation agents. And for whatever reason, the ryanodine receptor is stimulated in a pathological way. Massive amounts of calcium, doesn't matter about an action potential. Brain and nerves have nothing to do with it. The pathology is here. Massive amounts of calcium come out and interact with muscle, which is why the overall pathology associated with MH, it all stems from sustained muscle contraction, skeletal muscle contraction. Not only does a massive amount of calcium come out, massive amount of calcium stays out. And as calcium interacts with muscle and stays out, doesn't go back in, what do you have? Sustained full body muscle contraction. You go with that? Okay, let's do the last part. I have sustained muscle contraction. We talked about exercise. What is my body doing? You guys know you get hot when you exercise, right? Why do you get hot? Your big muscles are working and you're using ATP and degrading it to ADP, AMP, and preadenosine. Remember, breaking those high phosphate bonds, energy is created, but what is also created? Heat. That's right. So that's why the hyperthermia exists. That's why it is hypermetabolic state. All right. So now I'm burning lots of ATP. What is my body going to do? Try to create mitochondria is where ATP is created, right? What is my body going to do? It's going to try to create more ATP for my big muscles. So I'm going to use more oxygen. And then you said in the back, what is the byproduct, right? When you use your car, you put gas in, what is the byproduct that comes out? Whatever comes out of the tailpipe, right? In this case, oxygen goes in, CO2 goes out. And if we're using this machine more to a greater degree, what is the amount of CO2? Higher, which is another reason that when you exercise in an extreme way, you breathe faster, not only to suck more oxygen in, but to get rid of more CO2. Okay? So there's your, we talked about rigor. Rigor, all that means is muscle contraction. Heat, we talked about heat. We talked about creating more CO2 because of the hypermetabolic state. In order to create cellular energy, you not only need oxygen, but what do you also need? Substrate. And you also need, glucose, glycogen, in order to create cellular energy. Well, you guys know, right? You guys remember from physiology, aerobic versus anaerobic metabolism. Aerobic metabolism with oxygen, body's incredibly efficient at creating ATP. However, when my oxygen debt gets so high that all of a sudden I convert to anaerobic metabolism, meaning they can't stop. And at some point, the oxygen debt is so high, there's not enough oxygen to create more ATP. The body becomes inefficient. Look what it starts to create. Lactate. What is lactate? It's acid. It's acid. So acidosis, you've heard of acidosis, right? And acidosis, lactate levels that are higher and higher, acidosis that is higher and higher when untreated will lead to death. That's right. So now you know everything you need to know about malignant hyperthermia and why it occurs. Does anybody have any questions? So if you can remember the diagram, you don't have to explain this to your friends at parties, it's fine. But if you can remember the diagram, you know why in a MH situation, people develop muscle tension and rigor. You understand why people can develop hypoxia. You understand why it's hyperthermia. And you know why that more CO2 is created. Are we good? All right, so who is susceptible? And so someone said this is genetic and you should remember that for your testing. So it's genetic, right? It runs in families. I don't want you to memorize the incidence, and I'll tell you why, because no one knows the exact incidence of malignant hyperthermia. It's pretty rare. However, there are particular areas of the country where it's significantly more common. Why would that be? Think about Los Angeles, right? We're in LA. How many different types of people live here? A lot, ton, right? However, in certain areas in the country, if MH is prevalent in terms of the genetics, and those people are the ones that continue to spread the genetics and live in a small group, do you see how it's much more likely to be passed down in that group, in that small community? So there are, not for you to memorize, but there are communities where MH is more susceptible, not for any other reason, in that it is a small community, the genetics exist, and those people, procreate, and the same genetics are there. All right, so we don't know what the incidence is. You may never see this in your career. Has anyone yet helped? You guys are in clinical yet? Okay, good. Have any of you seen this? Nice. Can you tell us a little bit about your experience? I'd love to hear it.
It was already predicted. It was a 13-year-old with muscular dystrophy. So they already knew that he was at risk.
They already knew he was at risk. Good. So what did they do? What did you do with the anesthesia tech?
We just removed the SIBO and the sucks from the room.
Yeah. So you remove the SIBO, can't give it. You remove the succinylcholine, can't give it. So there's no way to make that mistake, right?
And wheeled in the MH card.
And we had the MH card available. Good for you. I love it. All right. The best way, so what they did was they knew that there was the potential and they avoided it, right? The best thing to do is to know and avoid it. We can provide a perfectly good anesthetic without inhalation agent and without succinyl choline. And if you don't give those two, the disease state is triggered by those two, the disease state doesn't occur. Good. Well, did the kid do fine?
Yeah.
Yeah, good. All right. So you said they knew. They knew, and I'm going to go over some people who may be at higher risk, but this is important stuff for you to know for your tests and for your boards. I just said we'd prefer to prevent this as compared to it occurring and treating, right? Makes sense? So if you guys, I don't know if Tony or Sarah or you guys in clinical have been going to pre-op. Do you ever hear the anesthesia people in pre-op say, we say this every time, have you or any of your family members ever had problems with anesthesia? Have you heard that? Okay, good. Why are they asking that? Why are we asking that? You guys too. Why are we asking that? It's for the hell of it.
Contraindications, just like get a sense of someone's history, if at all.
Good. So for instance, let's say the patient says, my dad had trouble breathing after anesthesia. That could be a million different things, literally a million. It tells me nothing about that guy, the patient. However, what if the patient said, and remember, most patients don't understand the medical stuff that you understand. What if the patient said, you know, my dad had surgery, 10 years ago, and afterward he developed a high fever, which can happen, right? But the anesthesia people told him that, he has to be really careful with having anesthesia in the future because the temperature could come back. That's like a holy crap, right? So do you see how you can go from very non-specific to specific? Now, with what the guy just told me, I don't know if he has MH, but am I going to take a chance? Absolutely not. I am not going to give him an inhalation agent, and I'm not going to give him sucks. Period. End of story. I'm not going to take the chance. Make sense? So pre-op eval is one way that we can pick up, is someone possibly MH susceptible? But, that's subjective, right? Okay. Is there an objective way to test for this? And it is. And this is in red, what you need to know for your tests and for your boards. There's something called a caffeine halothane contracture test. It is only done at a very small handful of labs across the United States. What a surgeon will do is take a small muscle biopsy from the patient, and they'll take the muscle, and a scientist will put the muscle in halothane, which is an old inhalation agent, and caffeine. And what they'll look to see what is the degree of muscle tension when you put that muscle biopsy in that concoction. If all of us are in this box, meaning I take muscle from you and it contracts that much, and I take muscle from me and it contracts this much. If this box is normal, someone who is MH susceptible, their amount of contraction, this is normal, their amount of contraction may be out here. And therefore, that test would be positive, saying that they are MH susceptible. If we have documentation, there's absolutely no way we're giving inhalation agent. There's absolutely no way we're giving succinyl choline. Make sense? Last thing. In the future, there is a genetic test for MH. It's not perfect yet because they don't know all of the genetic malformations that are associated with MH. So there are still false negatives associated with it. In the future, it'll become so good that we can do a blood test and then get that back and then see yes or no. Okay? So do you understand what we just talked about? Pre-op eval, not specific. Caffeine halothane contracture test. Muscle biopsy, degree of stretch in a lab. last genetic testing to see if someone has that genetic code. As you said, it's a genetic disorder. It works, it's good, but it misses sometimes because they don't know all of the genetics that are associated with MH. We good? Here is what you were talking about in your patient. So who is at risk for developing MH? MH is a muscle pathology. It is a genetic muscle pathology. However, they believe that MH is associated with other muscle pathologies such as these, and muscular dystrophy is a big one. What did you say your kid had?
Duchenne.
Say it again?
Duchenne.
He had Duchenne's. So look here. I put Duchenne right there for you. That is something you should know for your test for your boards. That's going to be on a test somewhere. Huh? But I just want you to know, clinically, there are other muscle pathologies that are associated with MA, not just Duchenne. Okay? Do I want you to memorize all of them? No. Do I want you to know Duchenne muscular dystrophy? Yes. And one of your classmates actually had that experience. That's awesome. Good. And you heard from him, when you work smart, things usually go perfectly fine. It's when you do dumb stuff that you harm patients, right? All right. This is easy. You guys know this. You told me this 18 times. Rarely does physiologic stress cause MH, but are triggering agents, so you know these two in red, right? I want you to know in red. Now, nitrous oxide is an agent that can be given by inhalation. And does nitrous oxide on its own stimulate the possibility of developing malignant hyperthermia? No, it doesn't. So nitrous oxide versus the inhalation agents are different chemical structures. It's the chemical structure of the inhalation agent that they believe causes MH. So if it comes up on a, these days, very few people are giving nitrous oxide with general anesthesia, but academically, I want you to know, you see how that's a nasty test question? Oh, you can't give inhalation agents. Well, nitrous oxide is given by inhalation. Can you give that? And the answer is yes. Okay. So clinically, not that significant because we don't give a lot of nitrous, but it's a really good test question, isn't it? You talked about this. Hypermetabolism caused by sustained muscle contraction. Read those. Are we good? Read them? Good. I'm going to go to the last one or the last two. So when you guys exercise, because you say you do, right? You get sore the next day. Sometimes if you lift heavy or do something that you haven't done, right? What is the soreness from? It's from the lactic acid buildup. But what you've also done is you've destroyed muscle in that area that has been destroyed and is going to heal. That's part of the process of working out. And muscles grow that way. Now, MH, not normal. When you have sustained muscle contraction that doesn't stop, you start breaking muscle down. Make sense? As you break it down, bad stuff happens. And I'm not talking about breaking it down like I did a chest workout, my pec hurts a little bit. No. I'm talking about breaking down lots of muscle in your body. Remember, this MH is not going to discriminate between muscles in my bicep and muscles in my leg. It's going to take care of all skeletal muscle. Therefore, muscle will be broken down. When you break down lots and lots of muscle or any amount of muscle, something called myoglobin is part of muscle and it gets into the blood. Usually you just pee it out, right? If you do a good workout, no big deal. However, if you break a ton of muscle down, myoglobin can actually clog the kidneys and cause renal failure. So we'll go over other complications associated with MH. Renal failure is one of them. In addition, what do you know inside a cell as compared to outside of a cell? What is the amount of potassium inside a cell as compared to outside of a cell? Inside, the concentration is higher or lower as compared to outside. Inside, the concentration is higher or lower than outside the cell. Significantly higher inside of the cell. So all of a sudden, I'm breaking down lots of muscle cells. As I'm doing that, what do you think can happen? Hyperkalemia, I love the fact that you use the correct medical term. Hyperkalemia, high blood potassium. Okay, are we good? And CPK is just a breakdown product of muscle. Don't worry about it. All right, here is important. So remember we said, what is the most important thing to do is to identify it as quickly as possible. If we'll have some time. You'll want a break. You'll come back. I have iPad Vitals to show you. It's really cool. I'm going to have you diagnose MH on looking at EKG, pulse oximeter, that kind of stuff. So we'll do that. Not all MH starts out rip roaring, right? Meaning that if you started exercising dramatically right now, everything goes up, right? CO2, heart rate, blood pressure, all of it quickly. But it doesn't have to. So sometimes MH is difficult to diagnose because sometimes the signs and symptoms are very dramatic quickly, and sometimes they're much slower in terms of their onset. Does that make sense? Right. There are two things in red. Oh my goodness, maybe you need to know those, right? So someone said in the back, how do you diagnose this? Did I ever talk to you about diagnosis? And it's not like you're going to be doing a lot of this, but you may be helping. So if you go to buy a car, do you buy the car and go, oh, it's a pretty blue, I'm buying it? No, you check to see the safety record of the car. You compare prices of cars that are the same. You look at all the features of the car, meaning that you look at a lot of different data points before you make the decision, I'm buying that car. Make sense? Same thing here. If the CO2 goes up a little bit, is it probably MH? No, CO2 goes up for a number of reasons. But if the CO2 continues to go up in an abnormal way, and we have other signs and symptoms, meaning we have other things that point us to that diagnosis, then we need to make the diagnosis of MH. Does that make sense? So no one's going to go, oh, the CO2 is a little high, they have MH. No. We're going to look at other things first. But if other things start to happen, then we start to get suspicious of its MH. All right. Why does it say rise in end tidal CO2 most reliable and increased heart rate first sign? Any ideas? Any thoughts? Yes, please. So these are both in red. These both happen, right? These are both initial signs. But it says rise in end tidal CO2 is the most reliable, whereas it says increased heart rate is the first sign. So what is the difference there between most reliable and first sign? Why is it not increased heart rate the first sign or the most reliable sign? Let's see. Yeah, do you have a thought on that?
Yeah, increased heart rate can be many things. So it's not like you know, you see increased heart rate and you're like, oh, I didn't have hyperthermia, right?
Right.
In order, so if you see increased heart rate, like that's abnormal, the second best way to like, or like the best way to like actually follow up on it is to check the end title.
Good. So I like the fact, so the first part of the question, there are many things that can increase the heart rate, right? If I had you sprint to the back and front 3 times, would your heart rate jump? Yes. Would your CO2 be significantly elevated? Because it's going to take you about 20 seconds to do that. Is your end tidal CO2 going to be significantly elevated with 20 seconds of really hard physical work? No, not at all. It's 20 seconds and then it's done. So first sign, increased heart rate of hypermetabolism. You were gonna say something else. Can you go to the most can you talk about CO2 as the most reliable sign?
I was just gonna base it off what you said, maybe less things cause a rise in end tidal CO2.
Good, okay. So we already saw the pathology, right? Muscle contraction, byproduct breakdown of creating more cellular energy, CO2. Are there lots of reasons the CO2 can go up? Not nearly as many as the heart rate. So, anesthesia technologists, I'm cluing you into something. Is there a reason? You guys are in clinical, you should know the answer to this. This is one of the things we would check immediately if we saw our end tidal CO2 going up. Is there something, anesthesia technologists, that would be significant and say the end tidal CO2 is going up for a specific reason that you guys know because you guys touch it every day? That's exactly right. So one of the things we're going to look at immediately is our CO2 absorbent exhausted? If it is, does this make sense? Yeah, it does. And if we change the CO2 absorbent and this comes down and we only had this, we feel much better. Okay, so good, CO2 absorbent. Anybody been in a laparoscopic case, watch laparoscopic surgery? Anybody see that? Belly full of CO2 gas? Not yet. It's CO2. They put gas in belly, CO2 in the belly. That can be absorbed also in the blood and raise the CO2. But as I'm going to show you when we get back, CO2 goes up a little bit. My granules are good. I'm just going to increase the minute ventilation. I'm going to make them breathe faster. Good. Goes up a little bit more. I'm going to make them breathe a little faster. But when we start to see it march up and up and up, and then we start to see an increased heart rate, and then maybe an increased temperature, now it's not like, now it's like, holy boy, I got to figure this out. And we'll talk about one way that will help anybody figure this out in a little bit. Okay? Are we good on that discussion? I want you to know this, and you guys already talked about, I want you to know what's in red. You guys already talked about that. Are we good? All the other stuff. Oh, yeah, see, I put it on, good. So what is the physical part of the anesthesia machine? You answered that. What is it? CO2 absorbent. Good. And then all the other stuff. But I really want you to know those first two. Are we good? Look at this. Initial signs. Well, we just said initial sign is increased heart rate. Well, looking, that's pretty big. Initial, that's 30%. But in the books, it says the initial sign is tachycardia. But this table is saying, oh, people can develop muscle rigidity as the first sign. People can develop fever as the first sign. What is that? Ready? Human physiology does not read the books. Just because the books say this is the first sign, in some people, it's not the first sign, which makes diagnosis more difficult. If this is the first sign, Are these things gonna occur soon after? You bet they are. Okay? So we can't look at physiology and look at a book and go, well, the book says this is the first sign. Because sometimes human physiology doesn't read the text. Does that make sense to you? Which is why we need to know all about the disease state. We need to know about all the signs and symptoms so that we as detectives can say, huh, that's abnormal. Let me look at other things. Oh, look, those two things are abnormal. In addition to this, I may have a problem. Yes? Okay. Treatment. If this happens, this is an emergency. Has anybody been in an emergency in clinical yet? Anybody been involved in it? Oh, can you please tell us? It doesn't have to be MH, just tell us.
Had a code airway
Oh dear, so a failed airway in the OR or somewhere else?
in the OR,
Okay, so,
ended up being just, they canceled it after we ran all the way across the.
okay. Do you know what happened?
No, we don't know.
Okay, all right. Was anybody in the OR when a crisis happened? Yes, so let's hear both of you guys. So you start. Yeah,
There was a bronchospasm in the
Right.
acute,
all right, good.
to saturate really fast.
Yeah, and do people, does everything get serious when patients desaturate? Oh, yeah, good, all right. What was your situation?
I think they were doing like a laparoscopy or something,
Uh-huh,
like they nicked an artery.
I hate when that happens.
So then I think they cut the patient open and then they like infused like
Yeah,
the tech had to set up a Belmont machine.
good, good, yeah, so that's hemorrhage, there's your crisis is hemorrhage. His is hypoxia and yours is hemorrhage, right? Let me ask you guys a question. When the patient started bleeding, when the patient got hypoxic, was there one person that took care of the patient? No. When there's an emergency, we don't take care of a patient with one person. We need multiple people. You had to set up a Belmont. Others were doing other things in order to help that patient. If we believe it's MH, it is not, it is a team sport. Make sense? You declare an MH emergency and everything stops. If we're giving sucks or inhalation agent, what do we gotta do? Stop. All right. Now, okay, sucks is good, would be given once at the beginning, so we're not gonna give that, continue to give that. But I turn the inhalation agent off. I think he's got MH. I turn it off. But then there's still SIVO in the machine. How do I keep that from getting to the patient? Any ideas? Yes,
Do oxygen flush?
you can do oxygen flush, but you're gonna have to ventilate the patient. And as you flush that, that is also gonna go to the patient.
Oh, take off the mask first.
Okay, so the patient's intubated. So are you saying flush the machine? And how long are you supposed to flush the machine for? What do they say as a technologist? Flush for 20 minutes. Yeah, a long time. What am I gonna do for 20 minutes? Right, yes.
I've seen them put like the charcoal filters on.
Oh, you've seen them put filter? You've seen them filters? There are filters for MA? Yes, good. Here they are. I'm gonna pass them around. If you come to Kaiser and Sarah is gonna go over the MH cart with you, right? In our MH carts, we're gonna talk about dantrolene in a second. There are these charcoal filters. As you pass them around, try not to pull them apart. One says inspiration and one says expiration. So one's gonna go on the inspiratory, one's gonna go on the expiratory lead. What it is going to allow is inhalation agent to come out of the patient, but no more inhalation agent to go into the patient. If you see the diagrams, the concentration of SIBO will fall almost within 2 or 3 breaths. Good for you. So these are charcoal filters. So you. Stick around. How much do you think those cost? Nope. $60. They're not expensive. They're not expensive. Okay. All right. So here, we'll go over MH protocol in a second. 100% cooling. Does everybody understand up to dantrolene? Read what you're seeing. Does everybody understand up to dantrolene? Okay. We're gonna go over dantrolene in a second. I want you to know something. I'm not big into memorizing doses, but I do want you to memorize what's in red in terms of a dose. You know why? Because that's gonna be on a test and it's gonna be on your boards. Question, how many people, I teach this all the time, to you guys, to my anesthesia students, so I know 2.5 per kilo up to 10 milligrams per kilo, not a problem. How often have I given dantrolene in my career? Once I helped 15 years ago. So if you don't review this in 15 years, you think you're going to remember 2.5 milligrams? Absolutely not. So what I want you to do for tests and for boards is I want you to remember this. Everybody, no matter who they are, gets an initial bolus. What does bolus mean? What does that mean? You guys know what that means? Rapid injection of 2.5 milligrams per kilo. Doesn't matter what the kilogram weight is. Why? Because scientists have determined that that is the minimum dose needed to start treating malignant hyperthermia. If you give less, it's not going to work. So remember 2.5 per kilo. If it's working, you can go all the way up to 10 milligrams per kilo. Trivia. How long do you think it starts? Do you think it takes dantrolene to start working? How long? Start. 6 minutes, which is pretty fast. Okay. Hold on, let me take it. All right, here, let me go to this. Remember this slide? How do you think dantrolene works? How does it work?
Does it allow for calcium uptake for the SR?
It does, but in a specific way. You're exactly right. If that's a disease process, it allows calcium to go back in. But what is causing the calcium to come out? RY, the ryanodine receptor. So dantrolene, lipid soluble, goes into cells, into muscle cells, desensitizes the ryanodine receptor. The sensitization is what caused the disease state. By desensitizing it, it allows calcium to leave the muscle and come back into the sarcoplasmic reticulum, decreasing muscle contraction and reversing the disease process. Does that make sense to you? If you can explain that to your friends at parties, that's fantastic. No one's going to ever ask you that question, but I want you to have a conceptual understanding of why the hell are we giving this, right? All right, treatment. Blah, blah, blah. So you should read through everything that is white. Now, remember I said to you, this doesn't happen often. We don't treat this. When it does happen, the signs and symptoms aren't always obvious. Kind of scary, huh? In the United States, it is funded by the US government 24/7, 365 days out of the year. You can call this number, phone number, 1-800-MH-HYPER. That's the phone number. And what you will do is you will get an expert in MH on the phone from the Malignant Hyperthermia Association of the US. We call it MHOUSE because we're too impatient. Okay. You can say, hey, I need some help. I'm a nurse anesthetist or an anesthesiologist or an anesthesia tech. I need some help. They will stay on, it is free. They will stay on the phone with you. They will listen to signs and symptoms. And if they believe that it is MH, they will stay on the phone and help you treat it. So there is no reason to not know how to diagnose this and treat this, even if you hadn't seen this in 25 years. Does that make sense to you? Okay, on the checklist, which I'm going to show you, you're going to see on the checklist, there's M-House. You should know, I don't care if you know the phone number, but you should know M-House. It's in red. You should know things are in red. Any other questions? Yes, please.
The Q 15 minutes.
Every 15 Q, yeah, sorry. Thank you for telling me. So remember they developed acidosis. Remember they developed hypercarbia. Remember they developed hypoxia. So an ABG and then, yeah, acidosis, hypercarbia, hypoxia. An ABG, as we're giving dantrolene, is going to allow us to see the process getting better. The amount of oxygen after 15 minutes of dantrolene should be higher. The amount of CO2 should be lower. The degree of acidosis should be less after I'm treating. That's an objective way to make sure the patient's getting better. Does that make sense? Thank you for this is, I don't need you to memorize this. If people get hyperkalemic, these are things we can do to combat hyperkalemia. We talked about they can develop renal failure. And when you guys exercise, you sweat, you lose fluid. Yeah. So guess what? People are going to need fluid. They're going to need IV fluid. You're going to want to make sure they're peeing. So don't memorize that, but there's a certain amount of urine we want to see. That's it. Okay. See, there's a lot in red here. What does red mean? Red means you should know it. Okay, so Tony or Sarah may have you calculate this, and I want you to know some stuff about dantrolene. And then I know I wrote it all out this time. It's all there for you, but we'll go over it. All right, a couple things. So what is dantrolene? Dantrolene is the antidote. It is the antidote for malignant hyperthermia. So we can decrease the amount of inhalation agent going to them. We can cool them. We can give them IV fluid. We can treat hyperkalemia. Nothing reverses the disease process that I've just said. Nothing. The only thing that reverses the disease process is dantrolene. So in the cart, in the anesthesia MH cart, you're going to have those filters. You will have cold compresses or cold packs to put on the patient's chest, but you will also have dantrolene, the antidote. So once you've identified they have MH, what is the most important thing? Getting dantrolene in their blood. That's the most important thing. All right. Important for you to know. Dantrolene must be mixed with, this is a test question, board question. With what? Sterile saline, E5W, or sterile water. Like right there. Right. And so why sterile water? Because the drug itself will, I have dantrolene, I'm going to pass it around. It will precipitate. It will become crystallized. So you must use sterile water. Will you remember that for a test? Should you remember that for a test? All right. Yeah. And there's a new product that I'm going to get to in a second. All right. This is in red, so you may have a test question on this. So it's going to ask you, how much dantrolene would you give initially to a patient who's 70 kilograms? So what is the initial IV bolus dose of dantrolene for everybody? Everybody, let's hear it. 0.45 milligrams per kilo. Good. So if we take 2.5 milligrams per kilo, the loading dose, multiply it by a 70 kilogram guy or girl, you get 175 milligrams, right? All right, now, we have two preparations, and I'm gonna go over this in a second. Actually, I'm gonna go over this right now. We have two preparations. We have one called Ryanodex. We have one called either Rabinodo or Dantrium. All three, there's actually another preparation. All three preparations are the same chemical. They are all dantrolene. The difference between this and this is not the chemical, is the concentration in this vial. This vial, the big vial, there are only 20 milligrams of dantrolene in this vial. I gotta give this patient 170, let's say 180 milligrams. There are 20 milligrams in this vial. How many of these do I have to mix up? 9. I have to mix 9 of these up just to give the initial bolus. That's gonna take time. Now, same drug in this one vial, 5 cc's. I will reconstitute with 5 cc's. In 5 cc's, there are 200 milligrams. How many milligrams do I need to give? 175, 180, like that, right? Like that, right? Do you see how I can put 5 cc's of saline, take this up, pull it out, each 1 cc will be 50 milligrams. Don't worry about this now. 50 milligrams, meaning that if I give 4 cc's, I'll give you 200 milligrams, and I can almost instantly give the loading dose. Kaiser has gone to Ryanodex. This has gone the way of the dodo. At some point in time, they won't even make this anymore, this preparation. It will only be the high concentration of Ryanodex. The advantage, you can give this so much faster as compared to trying to mix 9 of things. Does that make sense to you? All right. We'll go over the preparations. Okay, let's go over this. Let's see this. So how many, you came up with 9. Says it on there, but you came up with 9. All right, so 175 milligrams is what I needed. So now the question is, how many vials of this? 175 milligrams divided by 20 milligrams in a vial. 9 times 2 is 18, add a 0. So it's 9 vials is about 180 milligrams. Pretty much what I need to give. Are we good on the math? Do you understand that? Do we need to go over that again? Because I can. Are we good? Yeah, oh, we're good. Okay, good. All right. So that's one calculation for the big vial, for the non-concentrated vial. Look at Ryanodex. The difference, each vial has 250 milligrams, not 20. So if I need 175 milligrams, what I'm going to do is divide that by what? Divide that by 5. And therefore, 4 milliliters is about 200 milligrams. That's it. And I can give that really quickly. Makes sense? Let's look at the preparations. Here they are. Worried, but here they are. So I was just here. Let me pass this around. Don't break my. The vials are very, they're very hard. So that's mixed. This is the same stuff, and this is Ryanodex. So take a look at the concentration. So I'm passing around Rabinodo, and I'm passing around Ryanodex. I don't have dantrolene. Notice, are all the chemicals the same? Is this all dantrolene? All dantrolene, the same chemical. What is different? Concentration. Look, 20 milligrams, 20 milligrams, 250 milligrams. An initial bullet, they were using someone who's 140 pounds, which is about 6 kilos rich. They're saying 8 vials. 8 vials, 1 vial. Look at the amount of fluid that you need to mix. Remember we said each of these vials is mixed with about 50 to 60 milliliters of fluid. So I need to get a half a liter of fluid in order to mix the old stuff as compared to 5 milliliters of fluid to mix the new stuff. It ain't cheap, as you can see on the bottom. Dantroline's expensive. Usually it sits there. Usually no one uses it. It expires, and then we get new Dantroline. Okay. I had a student years ago say to me, well, doesn't that seem like a waste of money? And I said to him, well, you know, you paid for the airbag in your car. Have you used it yet? Like, no. I'm like, what if you need to use it? He's like, yeah, I guess it's a good idea. Okay. It is, if in the United States, it is a mandate, if you are providing general anesthesia, you must have either Dantrolene on site. You must be able to get Dantrolene, like if you're a standalone surgical clinic, that there, you must be able to run across the parking lot to get Dantrolene from the hospital. You can't not have this. And I'm going to tell you at the end why you can't not have this. You must have this available. Any questions on Dantrolene? Are we good? All right, differential diagnosis. So could it be something else? What if someone develops, what if someone has a ruptured appendix? Will they be tachycardic? Yes. What does tachycardia mean? High heart rate. Will they become hot? Ruptured. They're going to become septic. The people who become septic, when you get an infection, you become hot? Yes. So do you see there are other disease states that can mimic MH? So we call that figuring out what is the problem, differential diagnosis. Okay. And again, that's not really part of what you do, but I want you to know that when you're standing there listening to anesthesia people talk about, could it be this, could it be that? What they're doing is differential diagnosis. Look at this, mortality. Mortality before there was Dantrolene, and I would, just so you know, I'm old, but I'm not that old. Dantrolene came out in the 70s, but before Dantrolene, they didn't have it. Mortality rate with no Dantrolene was 70%. That's horrible. I work at Kaiser West LA. Our old chief of anesthesia was actually had many years ago a pediatric patient who developed malignant hyperthermia before they had Dantrolene, and the kid died. This is 30 years ago, 40 years ago. So it's real. Notice the mortality rate these days, pretty low. Why? Dantrolene, training. M-House, probably also. Yeah, and you can see mortality has gone down, which is good. Post-op concern. What is recrudescence is a big word, meaning it comes back. So let's say someone has MH. Treat it with 6 milligrams per kilo of Dantrolene. Taken to PACU, and an hour later, you're like, bye, discharge. No. They have to stay in the hospital for an entire 24 hours at minimum. They will be getting Dantrolene for the next 24 hours as an IV infusion. Because even though you initially treat the disease state, within that 24 hours, it can start to happen again. So this patient is not going to go home. They're going to go to the ICU. They're going to be monitored. They're going to get an infusion of Dantrolene. Does that make sense? Hemodynamics, we're concerned about their heart. We're concerned about their brain. I already talked about renal failure, right? They can develop renal failure. Here's one last one. You guys have probably never heard of the term, have you ever heard of the term DIC? Disseminated intravascular coagulation. You've heard of that, right?
Abbreviation.
Okay, oh, on
You know the name.
on abbreviation list. What happens is all of a sudden, people start to bleed. The platelets in your blood become consumed and people start to bleed from everywhere. IV sites, mouth, nose, eyes, things like that. DIC can lead to death. Malignant hyperthermia is an independent risk factor for the development of DIC. Okay. Why do we go over this? You guys are like, we go over this because we have a test. I understand tests. I understand they create a tremendous amount of anxiety for you. So look at this. This happened in 2008. And I heard about it. I actually heard about it on the news, on the local news, and I'm not sure why, because this occurred in Florida. So this 18-year-old girl who had just graduated from high school, was living in Florida, went in to have a plastic surgery procedure, totally healthy kid. Has general anesthesia during, and again, she's completely healthy. After she goes, no medical history, no known medical history. After she goes to sleep, the anesthesiologist starts to see that she becomes tachycardic. Okay, there are a million reasons, right? So he gives more anesthesia. Her CO2 starts to go up. Okay, I'm gonna check my granules. I'm gonna increase the minute ventilation. She starts to become, her temperature starts to go up. Have you guys been in the OR and seen how we cover patients and use a bear hugger? In the OR, as you guys know already, people lose heat really fast. They don't gain heat really fast. So that is unbelievably abnormal. She had a situation where she developed MH and developed it very rapidly, the extreme signs and symptoms. As you read the transcript, and I'm not a lawyer and I didn't read the legal transcript, but what happened is they delayed the diagnosis of MH for 10, 20 minutes. At some point, they could not deny the diagnosis because her temperature was like 103, 104 degrees. At some point, they decided that it was MH. They gave her 40 milligrams of dantrolene. An ambulance came to pick her up. They took her to an ER and she died. Okay. So let's not place blame, but let's dissect this. So what is the first mistake? What I just described. What is the first mistake?
Symptoms quickly.
That's right. Not only didn't they identify the symptoms quickly, when the symptoms were showing that it may be, they ignored them. And what's going to happen is they're going to get worse and worse and worse. Okay, so good. So non-rapid treatment. What is the second thing that was done incorrectly here as I described it? Proper dose. So let's say she's 60 kilos. That's about 130 pounds. I don't know how much she weighed, but let's just say. What's 2.5 times 60? That's 120 plus 150. They gave her 40 milligrams. They gave her way less than the initial bolus dose, meaning it doesn't have a significant effect. And as a result, she died. Okay. So the things that we talk about in class are important because you may not see them today, tomorrow. You may see them in 15 years. And you guys are part of the anesthesia team. you're gonna be part of helping us to manage this. Because if we don't manage it, bad stuff's gonna happen. That's a catastrophe. Losing a healthy 18-year-old with no medical problems, that's a catastrophe. You know, if you're 80 years old and have every known pathology and something bad happens, it's not a good thing. We hate that. But, you know, there's only a certain amount we can deal with in terms of keeping someone alive. Anesthesia is very safe, but in this particular case, it is an absolute catastrophe that someone didn't identify it and someone didn't know. Now, last question. Let's say this person, this anesthesiologist had never seen this in their entire career, but they knew something was wrong. Is there anything they could have done to help them make a diagnosis and a treatment? Phone number. What's that phone number? You don't know the number, but what's their organization? M-House, Malignant Hyperthermia Association of the United States. And they could have helped, right? Identify and treat. Okay. What time is it? All right, so why, it's 11:18. Why don't you come back in 10 minutes? So come back at 11:30 and then we'll do the second part. Because I want to get you out, I want to be done by 1 at the absolute latest. Also, when you guys go home, and if you're like, I don't really understand this, I need more, you can email me. Remember, you guys can email me. Just let me know who you are. Escape. Uh-huh. Yeah. So when we come back, your job is to, when everybody comes back and we start at 11, your job is to not let me speak 1 minute past 12:30, because I want to do some iPad stuff with you for the next half hour after that and get out at 1. Okay, so at 12:30, if my big going, tell me it's 12:30.
Oh, I have a question.
Yeah.
Like outside of the scope. For the drug that's the reversal,
Be specific, reversal, oh, thank you so much.
Dantromine?
Reversal of dantrolene?
No,
Or
Dantromine itself.
dantrolene, the antidote.
yeah, you said, put it in water, right?
Sterile water.
I get the purpose of it so that it doesn't evaporate. Does that mean it, okay, precipitate? Oh, that's why it's.
Precipitate, so precipitation is, for whatever reason, the drug, in terms of how it's formulated, will dissolve. Can I see it here?
Yeah, I've seen it's out of form.
Yeah, so, you see this? This must be sterile water, because it's completely liquid, right? I can check that. If I put saline or D5W, what would happen is, this wouldn't be in the liquid, it would be like all crystallized.
Yeah, like a little.
Yes, that's a powder, but it would just be crystal, you can't inject. That's why it's always gotta be sterile water.
Okay, that changes my question. I was gonna ask, if it was lipid solid or.
They're extremely, dantrolene is extremely lipid soluble.
Okay.
It has to be in order to get into the cells.
Are we directly going to the muscles or?
We're giving it and it's going in the muscles and it's also going in other tissues also. Doesn't just go now. Do we want to give dantrolene? No. See if we don't give it.
There's a highly, any known side effects of the brain?
Good question. The biggest side effect is muscle weakness. It makes sense, you know.
The only other issue associated with it is like all of our drug, like most of our drugs, it's broken down to the liver. So if you give lots and someone has some function, it can cause
like,
that. But
You
it's
really need to be
unlikely.
able hands-on, just kind of talking about it.
Okay. You're welcome.
It's one. Now, it's Oh, really? Wow. Football. Who's there? Yeah.
Well, maybe in the.
Okay,
Oh. Well, if you don't know, they're very high. Hmm. 15%. You remember? And I told them, like, oh, after tricks, come here to Woodland Hills after. And I go, it's bad, June. I was telling you. Should say. They asked. They asked for the. Posted.
Oh. Well, it's the east. Yeah. I'm like, yeah.
Question for you guys who are any of you guys doing clinical at a non-Kaiser? Okay, good. So in terms of the drugs in the OR, are they in a Pyxis or are they in a just a drug cart? In a Pyxis? Where are you guys? City of Hope. Okay, Santa Monica.
Yeah.
It is 11:30. Thank you, sir. All right, so here's the plan. My big mouth speaks for a maximum of an hour on this. We do 30 minutes of vitals to reinforce the information of MH and the drugs, and then we go home. Sound good? Good. All right, so totally switching from MH to pharmacology. So this was a pharmacology lecture of drugs that are not your typical anesthesia drugs. So it's not propofol, it's not a narcotic, but there are other drugs that we give to manage most often hemodynamics. And talk a little bit about antibiotics and so forth. Okay? You guys got that? All right, good. So here's the focus. Just like we did last time, we're going to focus on pharmacodynamics, meaning how does the drug affect the body? Does the drug make the blood pressure go up? Does the drug make the blood pressure go down? Does the drug make the heart rate go up or the heart rate go down? Okay, are we good? Pharmacodynamics. The second thing is the mechanism of action. How does the drug work? And the third thing is, what do you need to know about the drug? So for instance, if someone had MH, you certainly can't give them SIBO, correct? Good. Okay, I want to go over some terms because you may not know these terms or you may know them very well, but I don't want to make an assumption. So when we talk about cardiac contractility, the heart's a muscle, right? It's cardiac muscle. So when we talk about contractility, we talk about the degree of squeeze. And the degree of squeeze, another name for it, the physiologist term, is the inotropic state of the heart. And it's written there for you, the inotropic state. The harder the heart squeezes, what do you think is more, is increased? It's got blood in it, right? Good, I like it. What comes out of the heart, so cardiac output. Good. Vasodilation. What does that mean? Vasodilation. Say it again. Good, I want to hear you. The vessels are expanding. Vasodilate. So to take vessels here and make them dilate. Now look at this. Look at my silly hand. Maybe this will help. Why would you give a drug that's going to make the vessels dilate? What? So let's say the vessels are tight and we're going to make them dilate. Why do we do that? So when they're really tight, the blood pressure can be really high. When we dilate them out, make them bigger, it drops the blood pressure. So one reason to give a vasodilator is when someone has high blood pressure. Are we good with that? The opposite is true, vasoconstriction. So what does anesthesia do to the vasculature? Anesthesia, propofol, narcotics, Dex, what does it all do? It causes vasodilation. When you guys go in the OR, do you guys watch the blood? You guys get do people teach you a little bit about, what they're doing and what they're look at the blood pressure. you'll see a lot of times blood pressure tends to be on the lower side. As we've talked about, the anesthetic medications cause vasodilation. The anesthetic medications depress the heart, depress the inotropic state. So anesthesia in general tends to lower blood pressure. When the blood pressure is too low, what can I give? A medication that causes vasoconstriction. So here, my blood pressure is really low. I'm going to increase the pressure by causing the arteries to constrict. Does that make sense? Questions on that? Are we good or are we overwhelmed? Because I can't tell. Yes, please.
What do you give to make the muscles constrict again?
So we're talking about vasculature. We're talking about muscle. We're talking about most of your vascular resistance comes from arteries. So we talked about with MH, we talked about skeletal muscle. With the heart, we talked about cardiac muscle. With the vasculature, we're talking about smooth muscle. Okay. So then say your question again.
What can you give to cause vasculature to close?
Okay, so let's say it correctly. Vasculature to close, what is this? What would you call it?
More constrict, I guess.
Vasoconstriction. What do you call this? Vaso
Dilation.
dilation. Let's say it again. What is this? Vasodilation. What is vasodilation going to do to the blood pressure? It's going to bring it down. Think about this. Take a hose, a garden hose, and turn the water on. You have a garden hose that's this big and you turn the water on. And there's water coming out of the hose, right? Don't turn the faucet. Now conceptually think of, so the amount of water coming out of the hose is constant. And we have X amount of water coming out of this hose. If we leave the amount coming out the same, we don't change the faucet, what would happen all of a sudden if I made the hose this big?
It's gonna lower.
It's going to lower what is coming out of the hose. Now, let's say I got a hose and now the hose is like this big. What's going to happen?
It's gonna come out higher.
It's going to come out much, much faster. In addition, as it is really narrowed, what is the pressure in the hose? It's higher. And when I make it really big, what is the pressure in the hose? It's much less. How is that analogy? Help? Did I answer your question? Ask it one more time. No, it's okay. It's okay.
What is the drug that you use to?
Drug. We're gonna get to. We're gonna get to them. There are a number of different drugs we can give to cause vasodilation, and there are a number of different drugs we can give to cause vasoconstriction. Okay. So we're just going over terms. Do you guys understand the concept? Because we're going to start talking about drugs and I'm going to say vasoconstriction, vasodilation. If you don't understand the terms, you don't know what the drug is doing. So are we good? Bradycardia and tachycardia. You guys are going to take ACLS soon, right? All right. So what does bradycardia and tachycardia mean? What's the definitions?
Brady is a abnormal low heart rate.
Right.
Tachy is a abnormal high heart rate.
Good. So how about a heart rate of 61? Is that bradycardia or is a heart rate of 59 bradycardia?
Too hard to tell. It's right in the middle. It's on the
There's-
lower end.
There's a definition. There's a definition. Bradycardia is associated with a heart rate that is less than
60.
60. That's right. Now, you also, I'm gonna go into something else. You also can add take someone who is a marathon runner. Their normal heart rate at rest is going to be 40. Because their heart is so well trained. Is that normal? Take a guy who has severe coronary artery disease and has cardiac conduction problems, and his heart rate goes to 40. Is that abnormal? You bet it is. Okay, so low heart rate doesn't always mean abnormal. Okay, so if if bradycardia is a heart rate of less than 60, what is tachycardia? What's the definition? A rapid heart rate of greater than 100. And that heart rate, depending on depending on the EKG, may be completely normal. If you ran back and forth, you'll be in a normal sinus rhythm, but your heart rate will be increased. That's normal. Your body's compensating. Are there dysrhythmias associated with a high heart rate? You bet. You're going to learn all about them in the future. Okay. But today, we're just doing normal. We're not doing abnormal rhythms or anything like that. Are we good? Okay. Let's talk a little bit about cardiac and vasoactive drugs. What do you think vasoactive drugs are going to do? They're going to do two things. What do you think they're going to do? Vasoactive.
Gonna affect your blood vessels,
That's right. In what way? Two ways.
either increase or decrease
Okay, be specific. Sound like a physiologist.
blood pressure.
It's either going to cause vasodilation or vasoconstriction. There we are. Good. I knew you were right on it. I just wanted the terms. Good. All right. All right. So a drug, how does a drug work? A drug works on a receptor. So it's not the drug that does it. It's the drug that interacts with the receptor that causes a physiologic change. So there's some receptors that you need to know. And you guys have probably learned this in physiology already. It should be just review-ish. Okay, in the heart, there are beta-1 receptors. Beta-1 receptors. So have you guys ever heard of a beta blocker? If I gave a beta blocker and the heart is stimulated by a beta-1 receptor, but I gave a beta blocker, what do you think a beta blocker is going to do to the heart? Decreases heart rate. So let's look here. Stimulation. Stimulation is also called agonism. So stimulation of a beta-1 receptor is going to do what to the heart rate? Stimulation is going to do what to the heart rate? If I ran back and forth, my brain is going to secrete catecholamines. That's going to be an agonist or stimulus, don't write all this down, at a beta-1 receptor. When I'm exercising, what is my heart rate going to do? It's going to increase. So beta-1 agonism or stimulation is going to cause an increase in heart rate. I gave this example of isoprel, and I really don't want to anymore. I really want to give this example. Can anyone finish this for me? That's right. Epinephrine. Your body creates it and secretes it all the time. So epinephrine, you can give IV also, is an example of an agonist or a stimulant. It's going to do what to the heart rate? Increase the heart rate. That's right. If we can give a drug that is a stimulant on a beta-1 receptor, a stimulant at a beta-1 receptor or an agonist, we can do the opposite, as we just talked about. We can give a beta blocker, not stimulate the beta-1 receptor, but inhibit it. As we do, what is going to happen to the heart rate? Decrease. That's exactly right. Good. Examples, esmolol and labetalol. Now, what is your clinical application with all of this? Maybe I should have started there. In the past, we never used to have the complex Pyxis that we have now. These days, pharmacy stocks the entire Pyxis, right? And anesthesia people have access to that. In the past, guess who used to stock the anesthesia cart? You. That's exactly right. Do you guys still stock carts in the middle of the day? Okay, you guys still do, right? point. You're touching all of these vials. And if you're touching a vial, you should know what the drug does, right? Secondly, in an emergency, if someone says to you, get me labetalol, you know that labetalol is a beta blocker or esmolol is a beta blocker. You don't need to know the dose. You don't need to know more than anything about getting them the right drug and knowing that the drug is going to bring the heart rate down. Make sense? Lastly, let's say at your place, you're not stocking any drugs. Isn't there an anesthesia workroom? Aren't there a whole bunch of drugs in the anesthesia workroom? If you're grabbing a drug, you should know what it does. Okay. So examples of beta blockers. Has anyone seen the esmolol amp or labetalol amp? These are the most two common beta blockers that we give intraoperatively. Okay. I want you guys as a class, because I'm seeing some, I don't really know what he's talking about. And that bothers me a little bit. So it's a lot of stuff and it's all new stuff. So I want someone else to start. Someone start at beta 1. And as a class, you guys do beta 1 inhibition and stimulation. Someone start. I'll be your wingman. I'm not going to let anybody hit the ground. Go.
Like answer, fill it in.
Do a discussion that we just did. Discussion on beta 1 receptors. Where are they? What does it do when it's stimulated? What does it do when it's blocked? Go.
So beta,
And this is not just for him. This is because he's not the only student in here. So you can start, but other people need to speak. Go.
beta receptors are found in the heart.
Beta 1 receptors. Beta 1 receptors are specific to the heart. Check. Another piece of information. Someone give me something else.
They're stimulated, it increases the heart rate.
When beta 1 receptors are stimulated, also call that agonism or stimulation, heart rate increases. Perfect. Can you give me an example of a drug that would cause that? Epinephrine would. That's exactly right. Acetylcholine. Perfect. Someone talk about inhibition. Someone new. You guys want to go home by 1? I do.
Lower the heart rate.
So talk me through it. It does lower the heart rate. Beta blocker. Beta blocker. So a beta blocker for the heart is going to work on what type of receptors?
You know what?
Beta 1 receptors, right?
Yes.
That's so we're either stimulating them to make the heart rate go up or blocking them to make the heart rate go down. So good. Can you give me an example of a beta blocker that we may use in the operating room?
Esmolol.
Esmolol or labetalol are 2 beta blockers. You know how you know what a beta blocker is? If a drug ends in olol, it's a beta blocker. Okay? There's metoprolol. There's a whole bunch of olols. Okay? Are we good with beta 1 receptors? They are located in the heart. When we stimulate them, also called agonism, that is going to cause a drug that we can give to increase heart rate as a beta 1 agonist is called. We also can depress the heart. We would give a beta 1 blocker. As a result, heart rate would, an example of a beta blocker too, esmolol, labetalol. Are we good? I think we're good now. All right, let's get off the heart. Let's go to the vasculature. Vasculature has to do with vasodilation and vasoconstriction. Drug works on a receptor. We talked about this. When we talk about the vasculature, we are talking about alpha receptors, specifically an alpha 1 receptor. Okay, so just like we did in the heart, different receptor, different drugs. Stimulation of an alpha receptor is going to cause what? Stimulation is going to cause what? Vasoconstriction. That's perfect. An example of a drug. Has anyone seen phenylephrine yet? Okay, good. You've seen phenylephrine in the OR. That's a vasoconstrictor. How about epinephrine? Would that cause vasoconstriction? It indeed does. It will have a cardiac effect, but it also has an effect on the vasculature. How about ephedrine? Has anyone seen ephedrine yet in the operating room? You have. That's going to cause vasoconstriction. So all three of those drugs are alpha-1 agonists. They all cause vasoconstriction. Last question. Why would you give one of those drugs? Why do you want to cause vasoconstriction?
The blood pressure's low.
The blood pressure's low. Good for you. So the blood pressure's low. The patient's dilated out because they're bleeding. They're dilated out because they're volume depleted. They're dilated out because you're giving them a lot of anesthesia. Their blood pressure's low. Do this. Give a drug like epi or the ones we just talked about, phenylephrine, ephedrine, vasoconstriction, bring the pressure up. Perfect. See, you got it.
I'm awake today.
Did he end?
I'm awake today.
You're awake today? That's good. All right. Inhibition. What do you think? And I don't care that you know that you can just forget this example. There's not a lot of drugs that we give that cause inhibition of alpha-1 receptors. There are some. I don't really care that you know. But what I want you to know is we can give drugs to cause inhibition or blockade of alpha-1 receptors. Where are alpha-1 receptors again? In the heart, right? Nope. Vasculature. Mostly arteries, also on veins, but most of your vascular resistance and your blood pressure comes from your arteries. Okay. So if I were to give a blocker, an alpha-1 blocker, what is that going to, if stimulation is going to cause vasoconstriction, blockade or antagonism is going to cause? No, right. Why would you give a drug that is going to cause vasodilation? Because the pressure's high and you want to bring it down. Good. All right. Here are beta blockers. Here's an example of esmol. Here's an example of labetalol. Beta blockers are administered and they have an administered to. They're administered to a whole lot. That's just stupid. Let me just change it. They're administered. And inhibit what receptors? Beta blockers inhibit what receptors? Beta-1. Where are those located? In the heart. All right. And here are two examples. I put these up here for a reason. Can anybody tell me what the reason is? Because you're going to be grabbing drug vials. You're going to be looking at drug vials. They're the same drug. But if I don't pay attention, I could make an enormous mistake. So if we look at esmolol here and here, it is the same drug. However, it is the same concentration. But I will tell you this, if you're used to grabbing this one for 10 years, which is blue top, purple label, and then you see this, you don't know. Pfizer changes drugs. You know why? Because drug manufacturers sometimes all of a sudden have production problems with a drug. If Pfizer needs a drug, they're going to buy it from another pharmaceutical company. And the packaging, that's terrifying, right? My point, read everything. I tell my students that. The best way to make a drug error is to not pay attention. Okay? Now, if you didn't know the okay, so you guys are going to be given this drug, right? let's say you give this drug over and over and over again. You hand people the vial. But today they ask you for another vial. You go to get it out of the workroom. And this is not there, this is there. Are you gonna remember that it's 100 milligrams per 10 cc? You're not. But what you should do is go to the person you're handing it to and say, this is different. And then they can take a look to see if it's different in terms of the concentration. Look at this. Look at this. Is that dramatically different? This is twice as potent as this. So if I want to give 5 milligrams of this, I'm going to give 1 cc, right? Or actually, you know what? It is the same concentration. It's the same concentration. I'm sorry. You know why? The volume is twice as great here. So the volume is twice as great. The concentration is the same. You always know what the concentration is. It has to be put on a drug label. It's mandated in the United States. My point in showing you these is if you have any question, hand it to the anesthesia person and tell them, this looks different to me. Let them evaluate it. By doing that, you may absolutely positively prevent a drug error. Okay? Good? All right. Read everything. All right, look at these drugs. Nitroglycerin and nitroprusside. Same milligram dose, right? Are they different drugs? Nitroglycerin and nitroprusside? Do you see how easy it would be to confuse those names? They both start with nitro. What I want you to realize is the names are different. And if you're not sure and someone asks you, make sure you bring it to them and say to them, I'm not sure. I would rather you say, I'm not sure, as compared to hand me something that I asked for, I don't check it, and then I make a mistake. Okay? Are we good? That's it. We talked about 2 types of drugs. We talked about drugs that interact with a beta-1 receptor. We talked about drugs that act on an alpha-1 receptor. Drugs that act on a beta-1 receptor, beta-1 receptors are in the when we stimulate them, agonists of a beta-1 receptor, we do what to heart rate. When we give a beta blocker and inhibit beta-1 receptors, we do what to heart rate. Drugs work also on the vasculature, primarily alpha-1 receptors, which are primarily located on arteries. When we give a drug that is an alpha-1 agonist or stimulant, what does it do? It causes vasoconstriction. Why do we give a drug that causes vasoconstriction? Because the patient's blood pressure is low. We can also give a drug that has an inhibitory effect on alpha-1 receptors. As it does, what is it going to cause? Vasodilation. Why would we give a drug that is going to cause vasodilation? The patient's blood pressure is high. That's it. You got it. All right? Yes, please.
What are beta blockers administered to?
Say it again.
What are beta blockers administered to?
So they can be administered to a whole bunch of different things. So if someone's heart rate is really high, if they have a dysrhythmia, beta blockers chronically are used for people with coronary disease. They slow the heart rate down. By slowing the heart rate down, you decrease the amount of oxygen that the heart needs. So there are a whole lot of reasons that patients get beta blockers. In the operating room, we give it IV. The primary reason is to bring the heart rate down. Does that answer your question? Yes, sir.
To add on to that, yeah, you agree, correct me if I'm wrong. No, love it. For cardiac radicals, one of the main reasons they apply vasodilators is to obviously reduce the heart rate, well, blood pressure and heart rate. but it's also to help with getting them on the bypass machine. So if the arterial blood pressure is too high and they start doing the incisions on the vessels, then it'll be too much blood pressure, and then you'll have like a lot of like blood loss. So they want to prevent that. And then once they get them on the bypass, then I'm not really sure what they do, but they maintain.
Yeah, so in the future, one of my next lectures for you is not only going to be looking at heart rate, but is also going to look at other factors that affect the heart, such as preload and afterload. We've already talked about contractility. When you give a beta blocker, and we'll talk about this next time, so don't worry about this. When you give a beta blocker, it's important to know that it decreases the heart rate. But it's also, if you're giving it, really important to know that it decreases contractility also. And so you say to yourself, you don't need to know any of this. You say to yourself, why is that important? If you're giving an anesthetic, which depresses the heart, and then you're going to give another drug on top of it, which depresses the heart directly, you better be sure that someone has adequate cardiac function before you give that drug. Because if you depress the heart too much, you're going to have to decrease the anesthetic that you're giving, or have such low blood pressure that the patient's at risk for a stroke, having a stroke, or having a heart attack. Okay, that's more complicated. We're not going to talk about that because you're not going to be giving these drugs correctly. But in the future, we're going to talk about those factors. There's more to learn. There's always more to learn. Okay. Other questions, but I don't want you, that's good thinking. I love it. And you guys will understand more as you see other surgeries and apply the information. I don't want you to know all about what I just said. I don't want you to know all about what he just said. I just want you to know what we went over. Are we good? All right, next drug class. So we're going to get away from cardiac drugs and vasoactive drugs. Why do we give gastric prophylaxis? You guys see this in pre-op? Why do you has anybody held cricoid pressure? Why do you hold cricoid pressure?
Red stuff.
Say it again, dear. What did you say?
Probably because they couldn't see.
Okay, so you did something called, you actually were pushing on the larynx to improve their view. That you can do, because the cords are housed right there. Why did other people apply pressure directly to the cricoid cartilage? Okay, he said prevent aspiration. What did you guys say back there?
I was gonna say something.
Prevent aspiration. You would be exactly correct. What does aspiration mean? Yeah. So stuff coming up out of the stomach, and if someone's unconscious, so you're conscious, right? You ate a lot of food, and then you kind of barf some up. What would you do? You'd cough violently, right? As it got around your pores. Someone's anesthetized, they're not going to cough. That stuff is just going to go into their lung. And if puke goes into your lungs, so you guys erped every now and again, right? You erp a little bit. It burns, doesn't it? Imagine a significant amount of that going into the lungs. Imagine what that's going to do to lung tissue. It's going to burn it, and it's going to destroy it. So that's why we do a rapid sequence induction. We are concerned that someone is at significant risk for gastric aspiration. Has Tony or Sarah talked to you about groups that are at high risk for gastric aspiration? So I see some yeses, and then I see some nos. So let's hear, what did you guys learn? Who is at risk for gastric aspiration?
Patients.
So you did learn it. Good. Emergency patients. Good. All right, good. What else? Obese patients.
Patient.
GERD. Trauma. Diabetes. Hiatal hernia. Neonate. Yeah. So all those groups are at high risk. We're going to do a rapid sequence induction, but a rapid sequence induction and cricoid pressure is not perfect. People can still aspirate. If they do, wouldn't we want them aspirating something that's less acidic? The more acid and the greater the volume, the more damage is going to be to my lungs. Make sense? So look, we'll go over NPO guidelines in a second. There are drugs that we can give, here they are, in terms of decreasing the incidence, decreasing the volume, and also decreasing the pH. So let's go over this. So volume, do you understand what that means? So volume is amount, right? Second, gastric pH. The lower the pH, the more acidic it is. The more acidic it is, the worse it's gonna burn the lung. That makes sense. Very potent acid, very as compared to water. Which would you rather aspirate? Very strong acid or water? Me too. Okay. These are the drugs that we give. Metoclopramide, famotidine, Bicitra. I don't want you to memorize, I don't even want you to really look at this. These are the drug doses. You can have it there for whatever reason if you want. But these are the 3 drugs we're going to give, and they work differently to achieve what I just said. And we're going to go over that on the bottom. Okay? Are we good with the 3 drugs? Metoclopramide, famotidine, and Bicitra. We're going to talk about this table in a second. Before we talk about this table, I know Tony or Sarah or someone has talked to you about NPO guidelines. I know that's happened. Why do we have NPO guidelines? Yeah. So if an hour before my surgery, I ate like a half a pizza, that's not good. You know why? Because that pizza's still in my stomach an hour later. And as I go to sleep and all my stomach and all the sphincters in my esophagus relax, that pizza or pizza juice comes up and ends up in my lungs. That's why we have people we have them NPO. Okay. Do you know the guidelines? You're going to need to know this for your tests and for your boards. These are the guidelines. So clear liquids, we can have up to 2 hours. There's a difference between breast milk and infant formula. It has to do with the type of protein. The type of protein in breast milk is digested more rapidly, which is why the guidelines are only 4 hours. So mom could feed the kid and the kid could have surgery 4 hours later. However, if mom wasn't breastfeeding, but was using non-human, so mom's using commercially available formula, different protein, doesn't move through the GI system as fast, meaning that the guidelines are longer. So mom can feed the kid with non-infant formula, but the kid has to wait for 6 hours because we want to make sure that there's no residual formula in the kid's stomach. And then lastly, meal. So the old guidelines were 8 hours. Some people will say 6 hours. And this is a light meal. You know why that's not good? Because some people think a light meal is a pizza and a hamburger and fries. And a milkshake. Why not throw a milkshake in there? Would it be a strawberry one, a vanilla one, or chocolate one, or all 3? That's a Neapolitan one. She's doing all 3 at the same time, right? You know, this may mean like a piece of toast and, you know, maybe an egg or something like that, but it's not specific. Do you know these guidelines? You should for tests and for boards and for clinical. Last part on this. These are the 3 drugs I just mentioned up above: famotidine, Bicitra, and metoclopramide. You may need to write some stuff down here. Okay. Famotidine does what? Famotidine is Pepsid. You guys hear Pepsid on TV, or you can get it over the counter. What does Pepsid do? It is an H2 blocker. It blocks histamine receptors in the gut, in the stomach. It decreases acidity. If someone has really bad acid, Pepcid is a drug that'll work. You can get it over the counter. So what is Pepcid or promote? You could write Pepcid. I should just write Pepcid. Pepcid. The onset is 1 to 3 hours. So if I give it IV, it doesn't start working for 1 to 3 hours. It's going to do nothing for me right now. So what's the clinical correlation? If I have a patient who is at risk for gastric aspiration, and I know they're coming in the OR, I have to order the drug at least an hour ahead of time and they get it. Because at the time they come into the OR, if I gave the drug 5 minutes ago, it does nothing. Does that make sense? Okay. Famotidine or H2 blockers are really good at decreasing acidity. So put 3 arrows down. That's its claim to fame. It decreases the acid. What does it do to volume? The amount? 1 arrow down. So it actually does decrease volume, but not a ton. So primarily, Pepcid decreases acidity. Next, Vicitra. It's taken orally. We don't give this drug that often. It makes people puke. It's kind of nasty. It tastes like a really sweet tart. It's taken orally. It's an antacid. Look at the onset. Look at the onset. 5 to 10 minutes. Why? I'm drinking it and it's going right into my stomach. It's having an immediate effect. So the onset is fast, which is desirable, right? What does it do to acidity? Put 3 arrows down. That's good. Decreasing acidity is good, right? What does it do to gastric volume? The amount of my stomach. I just drank 30 cc's of this stuff. It increases it, and that's not what I want to do. So we can decrease acidity quickly, but we're gonna give up a little bit of what we want. We're gonna increase volume. Is that volume increase? Is that what causes the nausea? It has a really strong taste. It's not the volume, it's the taste that makes some people puke. So you guys know that the candy tarts? You know that? So I've actually tasted Vicitra because I'm like, I want to taste what it tastes like. Don't tell anybody I did that. But like if you took the entire roll of sweet tarts, opened it up and stuck it in your mouth at one time, that's what it tastes like to me. It's a really strong taste. Okay. The last drug, metoclopramide. Metoclopramide is called, you don't really need to write this down, a gastrokinetic, meaning it moves volume through the GI system. In terms of acidity, Vicitra does 0. It does, I'm sorry, I'm on metoclopramide. Metoclopramide does 0 to acidity. It doesn't touch it. But what does it do to gastric volume? Put 3 arrows down. So it really is good at removing residual stuff in the stomach and pushing it into the intestines. Once in the intestines, you can't ask for it. Okay? So let's summarize. Look, so if our goal is to decrease gastric volume and to increase acidity, we have famotidine, really good at decreasing acidity and kind of okay at volume. The bad part is it's going to take an hour just to start working. We have Vicitra, the antacid. That's going to decrease acidity now. However, it's going to do the negative of slightly increasing volume. Last, we have metoclopramide that does nothing to acidity. We have these other two drugs to work on acidity. What does it do to volume? It really decreases it. So by giving the three drugs in combination, we achieve what we want, decreasing gastric volume and increasing gastric acidity. So if someone does vomit, the damage to their lungs, fluid that goes into it, doesn't damage it to any degree. Yes, sir.
Can you combine them?
Combine them how?
Like,
So this is taken orally. This is the oral fluid, so no. And famotidine is given IV. It's given in a piggyback, so it's given as a IV infusion in a really small bag, and it goes in over about 20 minutes. And metoclopramide can be given. You don't want to push it rapidly. You want to give it slowly. All of these drugs, just so you know, especially by Citra, have side effects. So don't write any of this down. If I give famotidine really fast, I can have someone that develops a bronchospasm. If I give metoclopramide really fast, it's a gastrokinetic. It moves stuff to the GI system. The way it does that is by increasing acetylcholine. If I do that and give that drug really rapidly, people can have uncontrolled body tremors while they're awake. So every drug has a side effect associated with it. How is that? You didn't write any of that down. That's fine. So the answer is no, the drug should be given, they should be given independently. Are we clear?
Give like famotidine like pre-surgery and then like right before give like.
What most often happens is someone with high risk for gastric aspiration, famotidine and metoclopramide will be ordered in pre-op.
So you can give them like with each other.
Yes, you give them with each other.
Is that your question?
I thought you meant mixing.
oh yeah, but the way I said it now, how she articulated, I was like, yeah, no.
Yes, you can give all three of these drugs at the same time. You can't, if you're talking about IV drug and IV drug, you can't mix those two IV drugs and give them in the same syringe or something like that. I'm sorry, I thought that's what you meant, but yes, they can be given at the same time. Okay, thank you. Thank you for making me clarify that. Are we good? We've only got a couple more drugs to do. And I've only got a little bit more time, so why would we give an antihistamine? Allergic reaction, that's exactly right. So if someone has an allergic reaction, an antihistamine is given. How does an antihistamine work? What do you think it has? What do you think the effect is? To block histamine. That's why it's called an antihistamine. So in an allergic reaction, something goes into the body, triggers a mast cell to open up and dump tremendous amount of histamine chemical. When histamine interact with histamine receptors on tissue, people can develop rashes. They can develop bronchospasm and trouble breathing. In the worst case scenario, they can have little to no blood pressure. And you've also heard of people dying from an allergy, peanut allergy or something like that. So this is no joke. What is an antihistamine going to do? Is if histamine is going to interact with these receptors to cause the effect, give an antihistamine. You're going to do nothing to the concentration of histamine, but you are going to block the effects at the receptor level. And therefore, the allergic reaction doesn't happen. So for the most part, antihistamines are given in the operating room if someone has an allergic reaction. Which one do we give? Which one is the most well-known that we give IV? It's written right here for you. A big name, diphenhydramine, little name, more common, Benadryl. And why do we give Benadryl in the OR?
Antihistamine.
What? An allergic reaction, that's right, good. Talk to me about signs, let's say you're walking by a patient pre-op. And all of a sudden you see there's something not right going on with the patient. Could be 100 different things, right? Can you tell me some signs and symptoms associated with an allergic reaction? Rash. Okay, rash. Does everybody who develops an allergic anaphylaxis, a big name for that is anaphylaxis. Does everybody develop a rash? No. Okay, but check. What else? Say it again. Clammy skin. Yeah, sure. It's a shock state. That's possible. A lot of other reasons that people can develop clammy skin. What else?
Inflammation.
Inflammation. Be specific. Because I walk by a patient's room and I see them being anxious, and I don't think inflammation. You're right, though. Histamine release will cause inflammation. How about the lungs? You guys know, I won't ask you if anybody has really bad allergies. Have you guys heard of an EpiPen? I know you guys have. Why do people who have a peanut allergy carry around an EpiPen?
Because in the event of an attack, the Broncos.
That's right. So possibly respiratory issues associated with allergic reaction, such as bronchospasm. They can't breathe, right? Okay, check. So let's say I walk by a patient's room. They're cold and clammy. They're very anxious. They're having trouble breathing. What else? What else about a histamine release? How about, what do you think their blood pressure is going to be? Very significant histamine release. Isn't anaphylaxis a shock state? In shock, what is the blood pressure? High or low? Low. That's right. Histamine. So last part. I know I'm almost out of time. Histamine causes vasodilation, massive vasodilation. What is vasodilation going to do to your blood pressure? Drop it. That's right. Good. All right. I've heard a number of people say bronchoconstriction or bronchospasm. If that happens, we have a drug to help with that. Has anyone grabbed albuterol? Yeah. I see some yeses. Good. Albuterol comes as a mist via inhalation. And there it is. Albuterol, reason for use. What's the reason for use? Bronchospasm. Who's more likely to have a bronchospasm? Good, you know that. So albuterol can actually be given in pre-op to patients and then taken in the operating room and given more albuterol when they go to sleep. Albuterol is for bronchospasm. Good. Administration is an IV. Inhalation, I love it. Perfect. All right. Has anybody heard of the term, the drug Toradol? Okay. Toradol is a drug that can be used. You can write down, it's like IV Advil. IV Advil. It's a non-steroidal anti-inflammatory drug. An NSAID. Isn't that what Advil is? Yes. Advil is an NSAID. Let's not worry about the mechanism of action. It is wonderful for postoperative pain. Do you guys ever get to walk around the post-op area? You guys ever get to do that? You should walk through the post-op area. You're going to see patients very comfortable and not in pain. You would see some patients that are in an incredible amount of pain. Okay. We treat pain. That's our job. How do you treat pain? Most often with a narcotic. But we talked about narcotics. What's the negative of giving a narcotic? Makes people sleepy, causes respiratory depression, increases the time that they're in post-op. If you take Advil or a drug like Advil, does it cause respiratory depression? Advil. Does it cause you to be sleepy? Does it have any effect on your level of consciousness? Does Advil work well for pain? You bet it does. So Toradol is one of those drugs that we can give an advantage. I just mentioned them. Doesn't make people sleepy, doesn't make them have vomiting, doesn't cause itching, doesn't cause respiratory arrest, and we can use it to help decrease postoperative pain. Okay, so indication, we're going to scratch out mechanism of action, and indication, pain. Good, 2 more drug classes. I got it. 6 minutes. I know. Decadron. Have you heard of Decadron? Has anyone stocked Decadron? I see some yeses. Good. Decadron is given with almost every anesthetic. It's given at the beginning in pre-op. Why would we give Decadron? And Decadron, just so you know, is a steroid. Why would we give that? Anybody? Let me give you a hint. It's anti-nausea and vomiting medication, right? So steroids have an anti-nausea and vomiting effect.
Is that anxiolytic or antiemetic?
It's antiemetic. It's antiemetic. Steroid will do nothing as an anxiolytic. Anxiolytic, the most perfect example is Versed or a benzodiazepine. Yeah, you can give a steroid to someone and they'll have no depression in their brain at all. All right, so let's not worry about the mechanism of action. I'll go over this with you right here. Indications. What is the indication? Postoperative nausea and vomiting. Now, what is the incidence of postoperative nausea and vomiting in the general population having anesthesia? High. So many times we're going to give this prophylactically. What does prophylactically mean? Preventatively. That's right. So someone's not even going to have nausea and vomiting. We want to prevent it to happen. So many times Decadron will be given in the preoperative area. Okay. Decadron for postoperative nausea and vomiting. Yes, sir.
I'm not sure what's the mechanism of action for Decadron.
Yeah, let's do that right now. You can write down mechanism of action having an anti-prostaglandin effect. You never need to know that, and you never need to say that to anybody, and you'll never have to answer that on a test. Look at this picture here, because you're going to see patients impact. Has any question? Anyone had anesthesia and had nausea and vomiting? I have. It's horrible. If you get the stomach flu and you're nauseated and vomiting, you puke and then you feel better until you have to puke again, right? With the stomach flu. You have anesthesia, you have nausea, vomiting, you puke, and then 2 seconds later, you feel as bad as when you puked the first time. It is horrible. It is absolutely positively horrible. Okay. Why do people puke? This is conceptual, no testing stuff. There's something called a vomiting center in the brain. It's located in the medulla. And what this area is, it's called the CTZ, chemoreceptor trigger zone. It modulates nausea and vomiting. Nausea, vomiting is protective, right? If I eat some nasty food, I throw up. Why do I throw up? It's my body's way of getting rid of the nasty food, right? And not having any more of it in my stomach. Lots of things stimulate this area. I'm gonna go here. And I'll just go here for a second. Emotional, right? Has anyone seen anybody so unbelievably emotionally distraught that they throw up? So there's that input to the CTZ. For us in anesthesia, we're here under treatment related. So look at all the medications and their bigger list. All these medications sensitize this area in the brain to nausea and vomiting. So that's why the incidence is high. In a typical general anesthetic, how many drugs are we giving you guys? 10, 12, 14 different medications. Some people don't have the predisposition, but many people do. They estimate that the incidence of postoperative nausea and vomiting is about 70% without treatment. But that's why we give Decadron unless there's a reason not to, because the incidence of postoperative nausea and vomiting is high. How is that, sir? Is that good? You good on that? Any questions on that? Okay. These are examples, so I don't want you to memorize this at all. It's here for you. In the CTZ, they're not only prostaglandin receptors, but they're all these different kinds of receptors. The more different receptor types we block, the less possibility of postoperative nausea and vomiting. So I can give steroids, Decadron, that are going to inhibit this receptor. But another drug that we give constantly at the during an anesthetic is Zofran. Zofran works on serotonin receptors and on and on and on. So I don't want you to memorize this, but you know, someone may say to you, can you give me some Zofran? Someone may say to you, can you get me some Decadron? And I want you to know that these drugs do work on the CTZ. Okay, so don't memorize that, not on a test. Are we good? I've got less, it's 12:31, but this is easy. I don't know a lot about antibiotics, to be completely honest. When they order them, I give them. However, I do know one thing. What is the most important thing? From our perspective, it's written right here, and you should know that. From our anesthesia perspective, about antibiotics. What are we always concerned about? An allergic reaction. So antibiotics are a class of drugs that people can have allergies to. So that's what I'm always on the lookout for. Surgeons order antibiotics. I don't want you to memorize this because I don't even know this either. And every year I look at this picture and go, it's kind of cool. Different antibiotics, they're different classes, right? Penicillins, cephalosporins, erythromycins, blah, blah, blah. Man has figured out how to kill bacteria in different ways. So for instance, these antibiotics kill this protein that killed this bacteria. These antibiotics kill the cell, the wall, the membrane wall of the bacteria. These antibiotics, blah, blah, blah. So different antibiotics kill bacteria in different ways. Okay. In anesthesia, we give broad spectrum antibiotic, most commonly NSAID. You guys have heard of NSAID? Okay, you made that, we give that intraoperatively. It's called broad spectrum. What does that mean? Broad spectrum. That it kills good. It kills a wide variety of bugs. People are at risk for developing infection postoperatively. So just as we talked about giving Decadron prophylactically, because someone doesn't have nausea and vomiting, we don't want to get it. Antibiotics are given prophylactically most often. They don't have an infection, but we don't want them to get one. Does that make sense? Good. So I'm not asking you to memorize drug classes. They're all these drug classes. I'm not asking you to memorize mechanism of action because I don't remember that. But I do want you to remember class antibiotics are associated with what? An allergic reaction. Excellent. Sure. Give me 1 second. This will be fun. You'll like this. You guys watching? Hey. What's this? Heart rate. What's this? Saturation. What's this? And restaurant rate. All right. I'm gonna give a drug. I'm gonna give a drug right now. I want you to see what this drug is. I just gave a drug. What could that drug have been? Heart rate went up. Can you get heart rate went up? What is the receptor in the heart? Beta 1. I just gave a drug that made the heart rate. It's a beta 1 agonist. What did I just give? I just gave epinephrine. What happened? Blood pressure went down. Why would I just give a drug to make the blood pressure go down? What drug did I give? And how would that drug work? Good. So blood pressure is arterial, mostly alpha 1. And if I gave an alpha 1 blocker, which I gave you an example, but we rarely give them, what's it going to do? Cause vasodilation and bring the blood pressure down. Are we good with that? All right. All right, so I'll slow the heart rate down. And I did the induction of anesthesia, intubated the patient, put the patient to sleep. And they're scrubbing, the surgeons are scrubbing in and they're putting bed out on the patient. What do you see? I see a heart rate that's okay. Then laying the patient fine. You happy with that blood pressure? Why? Kind of low, huh? All right. Well, I don't want it that low. So I can give a drug to increase the blood pressure. What am I going to give? Can you give me an example? Give me an example of a drug that's going to increase the blood pressure. Okay. Hezbollah is a beta blocker, Olal is a blocker. Are we concerned about the heart now? We are concerned about the heart. Are we concerned with the heart rate? Okay, so if we're talking about heart rate, we're talking about beta 1 receptors. We're talking about the vasculature and alpha 1 receptors. So can you give me an example of an alpha 1 agonist that is going to help me bring up that blood pressure? Phenylephrine, an alpha 1 agonist, that's great. How does phenylephrine work? Does it cause vasodilation? Or does it cause vasodilation? Vasodilation. Excellent. All right, ready? Ready? I put someone to sleep and I intubate them. And they have end-tidal CO2. As you see. And the heart rate and blood pressure went up a little bit. Well, what's most concerning to you? Oxygen saturation is concerning everybody. What do you do? I have end-tidal CO2. Tube is between the cords because I'm getting end-tidal CO2. I'm seeing chest rise and fall. My bag compliance is good. I visualized the cords when I intubated. I saw condensation in the tube. What else do I need to do to figure out what this is? What would you do? Did you listen to the chest? The chest? And I'm going to tell you right now, I hear wheezing. Really bad wheezing on both sides. It could be an allergic reaction, but you know what? Look at her. Love that. You see what she did? It doesn't mean the next professor couldn't be in the toilet. It's an allergic reaction. But do you see what she did? She said, I'm not buying the blue car without knowing more about the blue car. I like it. Good. Let's just stay with it's a long issue. Let's stay with that for now. Get the anaphylaxis. I hear wheezing. What do you want to do? I heard the answer. Why don't we give albuterol? Albuterol did what to the lungs? It was a broncho. Why is the patient wheezing? They have bronchoconstriction. How do we offset that? Let's give a bronchodilator. That makes perfect sense, right? Okay. And all of a sudden, the wheezing gets better, and the wheezing gets better, and the wheezing gets better. Okay. That's good. Did we do beta blocker? No, we didn't. What if that happened? Okay, do we want to give Esmolol with a heart rate of 45? How do we make the heart rate go up? An agonist such as epinephrine. Heart rate was really, really high. How do we slow? Ooh, gee, that's really high. How do we slow? How do we slow the heart rate down? Beta blocker. Example. Good. Or Esmolol. Good. All right. I want you to watch this really carefully. Okay. So just watch everything. So patient's doing fine. Oh, no. Can't do that without you seeing. So. We got a problem? What's our problem? What's happening? Okay, so we're seeing things in tandem here. So our heart rate went up because our blood pressure came down, right? It's compensatory. The heart is trying to bring the blood pressure up. By increasing the amount that it's injecting. Cardiac output. Blood pressure low. Sat low. Did you notice a change on this? Okay. Have you learned about end-tidal CO2 waveforms yet? Okay, a long time ago. You'll review it. So I see her doing. She's doing this. She's doing this. What does this mean?
Inhalation isn't as like big.
Yeah. So exhalation. Yeah, or exhalation is depressed. If I have any kind of hypoxia, what am I going to do? Listen to the chest. Patient's wheezing, which would suggest that waveform. That waveform and that blood pressure don't. Remember the last one where it was isolated bronchospasm? What was that blood pressure? High, because the patient was stimulated and their brain wasn't asleep, and that's why they had a bronchospasm. But this time, blood pressure is really low. Why is the blood pressure low? And the sat low, and the end-tidal CO2 waveform slow. Because it's not simply a bronchospasm just because I intubated him. It's a bronchospasm because possibly it is a sign associated with anaphylaxis. I look at the patient's body, and I also notice that he developed a new onset rash across his chest. Yikes. What do I give? What do I give? Oh, wait a second. I missed. Right before I did this, 3 minutes before, started his antibiotic. Cause and effect. If I had told you that, and then you see this, you think to yourself, what did I just do? What changed and why did it change? Allergic reaction. How do you treat an allergic reaction? What's one drug we would give? An antihistamine. What is the name of that drug? Benadryl. That's right. Good. All right. One last one. Oh, and so here, let me. Okay, so let's go back to a normal end-tidal CO2 waveform. 2 seconds. See how this looks sloped? You see how this doesn't look sloped? Okay. How do you know which side of the waveform is expiratory and inspiratory? Anybody know? How do you know which side is expiratory and inspiratory? One side is expiratory, one side is inspiratory. How do you know? Really easy way. You know don't ever tell anybody I ever said this to you. You know the song, Old MacDonald had a farm. E-I, there's no O. So expiratory is always first, inspiratory is always second. I'm a little bit messed up, so that's so close. Okay, one last scenario. Patients having anesthesia. They're having an outpatient gallbladder removal. Patient's 40 years old and completely healthy, right? What is that? Nothing, you're right. What is that? Okay, so it looks perfectly white. And there's a way to quantify, right? You can look at inspired CO2. That's, do you guys know that? So you can look at purple, but purple, you know, Dave told you that it could be purple on the inside and yeah. How do you quantify it? How do you know specifically? On the machine, it's not good. Not only does it show you end tidal CO2, what is coming out of the patient, it will show you inspired CO2, what is going into the patient. If that number is a high 1-digit number, like 8, 9, 10, 11, the Sotasorb is exhausted, okay? How do you know it's malignant hyperthermia? Okay, here's my question. With those vital signs, would you say this is MH? Meaning, it's an emergency. Stop. Call M-House. Everybody come in. We have an emergency. No. CO2 went up a little bit. That happens constantly. Let's say this, the CO2 granules are not exhausted. All right, went up a little bit. Blood pressure went up a little bit. So that's fine. What am I gonna do? I'm gonna increase his respiratory rate. No, not that much. I'm gonna increase his respiratory rate on the vent to blow off more CO2. That's not that high, and that happens all the time. What are you seeing? What's concerning you? Everything's okay. Not bad. Not bad. Okay, not bad. When I turned this up, and this started going up pretty fast. And what I should see is at least staying or kind of moving in the opposite direction, and it's not. It's moving up fast. Is there anything else that is not on here that I could look at? I could look at temperature to see if it's increasing also. What do you guys think now? Earlier you were like, no, that's not MH. And then you were like, gotta think about it. Now? Okay, so what I'm gonna do is I'm gonna turn up the ventilation, but if I still start seeing this, we got it. Now it's the MH emergency. Now it's the whole bit. Okay. So we see the initial vital signs every day, all the time. We don't treat it as MH. We do other things to see if it's going to come down because most of the time it's not MH. As you see things getting worse in a quick way, and temperature, which is on there, you have to say to yourself, well, this is MH, or the possibility. What could we do? We could declare an emergency, get Dantrolene ready, and we could call. I think my work is done here today, guys. Did that help you? Did that, doing that, did that help you understand some of the abstract concepts? Very good. What time is it? 8 minutes. I got 90 minutes already. Pretty good. All right. So if you have any, I'll be up here for a couple minutes. If you have questions, if not, go home. Sarah will do her, she's sick. We'll do her lecture another day. Got the flu or something. And then if you don't have any questions, you can email me if you want. Go out, go home, get on the freeways.
Love
Yeah, fast. On a low level.
You too.
Thank you.
You are welcome.
Go ahead and help back. Help her back. I don't know what you're talking about. Yeah, that's. Hang on. Yeah. Next week. Yeah, next. You're
Max, put up my phone.
I got it. I haven't seen it.
Hey, come help me.
Oh,
So we had Zoom,
how to turn it off?
yeah, starting in fall. So look, I didn't give that Zoom.
I know.
No, tell me what to do.
Right. Oh, I want to go.